In terms of, Rochelle's done an amazing and thorough job we've mentioned of introducing the mealtime assessment with people with intellectual disability and dysphagia support needs. And now we're going to move a little bit into thinking about intervention. But obviously that's a humongous area, and just to frame it for you, the focus of the next half hour is really around how potentially we plan and monitor our interventions, not so much the content of your intervention. Right, how do we go this? So just very briefly to start off with, if we have a look at the Speech Pathology Australia clinical guideline for dysphagia, it clearly identifies that as speech pathologists we have a role in screening procedures for dysphagia, we have a role in assessment, which we've just been focusing on, we have a role in intervention and a role in monitoring intervention and monitoring people's support needs after intervention. So in terms of intervention, I think what I just want to clarify here is the clinical guidelines talk about the development of a management plan, but they clearly explain that that term is being used broadly. So that might mean your recommendations within a report, it might mean a mealtime management plan or an eating and drinking plan that you develop. It might actually refer to your intervention that you're implementing. So throughout the next half hour, I might say any variety of those terminologies. But I think what's really, really important to note, and we must reflect on, is that for interventions to be effective, they must be adhered to. A mealtime management plan is worth diddly squat if people aren't actually implementing what's on that plan. And that's really the theme of this next half hour. Okay, so if we have a little look at my experiences to date, over the past 16 years, I've worked predominantly as a speech pathologist in the disability sector. During that time, I've had little bits of experience in the NGO sector, in private practice and in the hospital setting over in the UK. And I have developed a lot of mealtime management plans in that time. I've talked to a lot of people about mealtime support recommendations, and that's been around a range of environments. So I've worked with babies from discharge back to home out of hospital through to older people with disabilities who've moved into aged care facilities and the lifespan in between that. And that means that I have been working with people around their dysphagia support needs in environments such as their private homes, supported accommodation settings, day placement, respite, mealtimes in the community, schools, aged care facilities. And overwhelmingly, I would sum up my success with mealtime interventions as hit and miss. So very often there's great outcomes and people are adhering to recommendations and implementing them. And then there's other circumstances where I'm at a loss of what to do because I have tried everything that I know to do and I can't get people to implement the recommendations. I'm seeing lots of nodding heads, so I'm feeling warm fuzzies now that everyone's kind of on the same page as me. So I think this leads to some really good clinical questioning. So as a starting point, I really want to have a look at what the current status quo is around, are people, what does the literature tell us, are people implementing mealtime recommendations? And what we know, and like a lot of things in intellectual disability and the field, the disability sector, there's not overwhelming volumes of literature and research on this, but there is some. And you'll particularly see Chadwick and colleagues referenced a lot. They had multiple studies across the 2000s, about every 1 to 2 years, a different study in this area published. And so what we know from Crawford and their colleagues is that the range of adherence to mealtime support plan recommendations in an adult day program facility was 64 to 100%. Quite a significant range. Kind of fits with the whole hit and miss thing, really. Whereas Chadwick and his colleagues in 2003 identified bit over 75% adherence to recommendations for persons, or it was adults with intellectual disability who were implementing suggestions themselves. So some of those people were independent eaters or adherence by their support people. Except, and there's a massive exception here. So this study broke down the features of the recommended strategies into categories. So they categorised information that was about food and fluid modification, whether the strategy was in the category of positioning supports, whether it was in the category of utensil and equipment use, or whether it was around mealtime partner support. And that captured things like pacing, observing if the person had already swallowed before you gave them the next mouthful, supervision. It included preparation of bolus size, so if a sandwich had to be cut into a certain number of pieces. And what that research found was that there was much poorer adherence to mealtime recommendations for that category of mealtime support strategies than for the other categories. So the 76.5% was the other categories. I think that's a real feature, so we'll come back to that. Their research also looked at the fact that there was less support worker adherence when working with people who were independent with their mealtimes. So if someone was self-feeding but still needed some support, maybe prompting not to rush or overfill their mouth, they were the type of strategies that were less likely to be adhered to. And the setting and type of carer impacted on levels of adherence. And family members, particularly parents, had less consistent adherence to mealtime recommendations than paid support workers. In regards to specifically children with dysphagia, there was little evidence. There was not much at all. So Crawford referred them, they basically said, look, there is no evidence specific to dysphagia adherence. What if we generalise this to other types of medical recommendations or allied health professional recommendations? So their literature review that looked specifically at asthma plans, dermatology plans and eye treatment plans found this huge range of compliance by parents and caregivers, 30 to 98%. And it's absolutely no surprise that there was a huge range of influencing factors that seemed to correlate with levels of adherence. And mostly it was about the number of comorbidities, so the severity of the disability that the child had. And then some quite old literature by Griggs and colleagues identified that parental adherence to recommendations following video fluoroscopy of children who had multiple disabilities was not observed. And what was fascinating about that research paper is that the process taken was that the parent had actually sat with the speech pathologist and gone through the video fluoroscopy recording, and it had been explained how the it's like I've got a line here, like an invisible line, and it goes. Had been explained how what you were seeing on that video fluoroscopy was driving the recommendation that the speech pathologist gave. Okay, so the literature then also made some suggestions for what was the barriers to adherence to recommendations. Family sense of self-determination was noted, and that was noted in the context that the less parents felt that they were driving the recommendations, the less likely they were to adhere to the recommendations made to support their child's mealtimes. It was also identified that, in the next two bullet points, this research by Chadwick and colleagues actually then got carers to self-rate what were the hardest recommendations to implement and the ones that they were most likely not to implement. And the number one thing that was identified were those mealtime partner skills, like I mentioned before. People had good reflection that they were the recommendations they found hardest to implement, And that was closely followed by modifying foods and fluids across environments. So there were, qualitative comments to the extent that I'm okay with the food if it's just a meal at home, but if we want to eat out of home, I can't manage the fluids when the temperature changes, or I can't modify the food appropriately if we go to grandma's house. Interestingly, those same authors identified in a later study that poor self-awareness by people implementing the plan was a barrier to adherence. And in this study, and I'm starting to laugh because I think we've probably all seen examples of it, in this study there was a small percentage of direct care workers who rated themselves as complying with everyone's mealtime management plan 100% of the time. And there's no surprises probably that on observation of care workers implementing the plans, that those particular care workers had the worst levels of adherence to the plan. So this issue of self-awareness and reflective practice skills in the person who's implementing the intervention. And then also, as Rochelle mentioned as well this morning, the workplace challenges for paid support workers. So things like supervision spans for staff identified shift changes or having new staff come into a service as a time of risk for not implementing recommendations, that type of organisational stuff. Okay, so kind of still doesn't answer our question for us, that for interventions to be effective, they must be adhered to. We all know that if our dysphagia intervention is not adhered to consistently, there will be increased risk for the person with dysphagia and decreased positive outcomes. On the reverse side, what we're aiming for is good, consistent adherence to the intervention to decrease risk and increase positive outcome. Now, if anyone had the pleasure of being at the Sydney Paediatric Feeding and Dysphagia Conference last year, you would have heard Suzanne Evan-Morris speak throughout the time of the conference. And a recurring theme constantly through her presentations was good clinicians need to ask good questions. And I think where we've got to at this point, there is a very clear clinical question here. And that is, how can we improve adherence to dysphagia management plans using that term meaning dysphagia intervention, dysphagia recommendations.